AFMC is really known.
And also make sure
Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Dr. Kristen Martin, and she is board certified family practice physician and in addiction medicine. And she is also CEO and owner of River Valley Medical Wellness. Dr. Martin, thank you so much for joining us today.
Thank you, Robin. I'm glad to be here.
Me too. So let's get started. So tell me, is there an opioid problem in Arkansas?
Absolutely, there is. And we've heard a lot about it nationally, but I think whenever we hear about national numbers, we wonder how does that apply to us in our communities? Right now, the CDC ranks Arkansas as the second highest prescriber of opioid prescriptions per capita in the entire country. And we do see this in our communities as far as being reflected in so many of the overdose deaths that we've seen and just difficulties that we see day to day, whether in our emergency rooms, our homes, on the newspaper, and things like that.
And is fentanyl a part of the problem?
It is. So there's two different kinds of opioid problems. In basically, you look at the opioid prescriptions, right, as far as the number of prescriptions that may go out per household or per patient that's in the state. And then there's also the illicit opioid problem of fentanyl. And we know that fentanyl has become more and more on the rise. We're seeing it cross the borders. And what a lot of people are having happen is that they can't get the prescription from a provider anymore, or maybe they're overusing, and so they may buy them off the streets as pressed pills. That actually, when they say pressed pills, it means that they have fentanyl or one of its byproducts, analogs, that has been pressed into a pill that may look like an oxycodone, may look like a hydrocodone, or another pill like that. And so we often see overdose deaths from that because nobody really knows the milligrams or the amount of substance that they are getting, and they certainly don't know necessarily that it's fentanyl, thinking that it's something else.
And you mentioned Arkansas is ranked second
in the nation for opioid prescriptions per patient, per individual. So, we're only beat by Alabama in that, but we're still, I believe the number is 75.8 opioid prescriptions as far as per capita, and that's a lot. It's come down. We've made some improvement. Prescribers are getting more mindful. There's some different efforts in place, but that's still not the second place ranking we'd like to be.
And what should healthcare providers know about prescribing opioids? What do you suggest they know?
So first of all, I think that any time that we're prescribing opioids, whether it's in an acute care setting, an urgent care or an emergency room, or whether it's in an office, we should always consult the prescription drug monitoring program. That's set up to be beneficial, not only as far as the patient being able to look and make sure that there's no overlaps of drugs, but also to the prescriber to be able to get a better history. A lot of times patients will say, well, I've run out and I need this prescription. And then when we get to look on the prescribing database, we can see, well, wait a second, they've run out 10 days early. And that allows for us to have a conversation with that patient, not accusatory, but be able to have a conversation with that patient and say, hey, what's going on here? And, maybe their pain's not being controlled. Maybe it was a lost prescription. Sometimes we find that there's somebody else in the household that's been using some of that. And so maybe not the problem with the patient per se, but for somebody else in the household. But these are all conversations that physicians should be having with their patients. So it's really supposed to be required by the Arkansas State Medical Board regulations for us to look at that each time before we prescribe an opioid or other controlled substance. It may or may not always happen. And certainly, whenever we're prescribing opioids, we're supposed to prescribe Narcan or naloxone with it, right? That's something that a lot of prescribers may forget about, but always even know that requirement is about the first time that you prescribe them opioids, or if they have co-occurring prescriptions of opiates and benzodiazepines. The fact of the matter is I find that a lot of patients have never received that Narcan prescription for different reasons, or they may have never been educated on the significance. So I tell people, When you go and get that, at least get one for your household. I'd love for there to be naloxone in every single home in Arkansas so that it's available for use. Being able to have that sometimes has been limited because there may have been a copay on that. It may have been a weekend. So if I'm working in the emergency room in a rural health environment, I prescribe somebody something for kidney stone, or maybe they broke their leg or ankle, and they legitimately need a short-term prescription for opioids. If I prescribe that Narcan to them as well, which I should, it may be that they can't pick up that because all of their pharmacies may be closed on the weekend, right? And a lot of times they'll find a way to go get the prescription for the opioids, but don't always pick up that second one because of the extra cost or the availability or different things like that. And so it's a real problem if we don't have those substances together, both the treatment and the antidote.
And is the antidote something that you see prescribers or PCPs within the state using? Are they prescribing it a lot? Are you seeing that as something that's frequent?
We're seeing more and more naloxone prescriptions written. But what we find is that there's so much stigmatization, right? There's so much bias and opinions that occur that a lot of times I will tell a patient, I prescribed you, some hydrocodone to help with your broken ankle this weekend and a naloxone prescription. Here's how you need to use it, and educate them. There's a lot of the patients and their families that become very offended. Why would you prescribe this to me? I'm not an addict. I am not that kind of person. And they have all of these different language and feelings and bias, which makes a lot of prescribers not want to endure the conflict. But the fact of the matter is, if we realize as physicians that this is about the safety of not just them, absolutely they may be taking something prescribed well. But what about a child that's in the household that may accidentally take a pill? We know that there's the saying that one pill can kill. What we're talking about is young people, right? A child that may be 4 years old that somehow comes onto that prescriptions and takes that without naloxone being in the household. That child could very likely overdose and die. And so this is not about stigma. This is not about any kind of thing other than true public health and good medical care.
And what changes are you seeing? Is there a different type of drug that's on the rise?
We are definitely seeing different types of drugs that are on the rise. So the xylazine, worrying about that, that's a tranquilizer that's being mixed now. We see different fentanyl analogs, carfentanil, ones that are 1,000 and 10,000 times more potent. So tiny little amounts, a grain of sand amount that can be exposed to somebody that can cause them to have overdose. And as the different organizations that are providing illicit substances, whether that's cartels or foreign countries or things like that, whatever it is, the fact of the matter is when you have that kind of potency, then it is even more alarming because 1 dose of naloxone, 2 doses of naloxone may not help. And you put in tranquilizers, benzodiazepines, and other substances mixed in with such high potency opioids, then the ability for somebody to overdose is just so much more increased whenever you have all of those mixed together.
And you mentioned education about Narcan. What type of education should PCPs, healthcare providers, provide to their patients about opioids?
So I think as far as, first of all, always letting people know that these are substances that people can become dependent on and sometimes then become addicted to. There's a difference in dependence and whether that's physical dependence, psychological dependence, and that's probably a whole nother airtime to discuss all those different things. But, there's lots of people that say, well, I've never had a problem. Nobody in my family's had a problem. What we know is that just with 7 days of use of an opioid, that 1 in 10 people, no matter what their background, socioeconomic, where they come from, anything, 1 in 10 people will still be on that opioid a year later, right?
Wow.
And so it's not a matter of trying to discriminate against anybody or anything else like that. That's just the realities of the medicines and people's reactions to them. And a lot of times there is some accident that causes chronic pain, right? But I think always educating our patients that there is that very real likelihood. Always being able to educate them about how different mental health conditions can also be related. Anxiety, depression, PTSD, how people experience pain. When they have traumatic events, their feelings of pain or how they process that can be so much greater that what can turn from treating pain that is physical pain and injury, sometimes it's very difficult for them to differentiate in between the physical or the mental and emotional pain and the physical pain, because the brain processes all of that in the same place. Whether it's anxiety, depression, PTSD, physical pain, it's always the brain that modulates that. And so many times a patient may have difficulty differentiating, but it is our job as a physician to help screen for that, help them with that process, and to provide the support, whether it's medical or get them the mental health support that they need for that.
How does AI and online pill services affect opioid epidemic?
So I really think that there's a difference in telehealth and in AI. During COVID, we really were fortunate to be able to use telehealth to reach so many people. I had patients that needed help. They were cancer victims, right? Undergoing chemotherapy and had very real issues that they were working on dealing with, and they couldn't always come into the clinic. It wasn't safe for them to get out. And so we were able to provide them care in a manner that was appropriate for them and be able to help out. But more and more, there is a push from certain organizations that I think is reckless as far as not putting truly the patient first. There's not as much accountability, right? Anytime that we have controlled substances, whether they're opioids, benzodiazepines, stimulant drugs for ADHD or anything like that, even gabapentin, that if we are not having those patient contacts that have some accountability, see how those patients are doing and really assessing their care and some of the testing that needs to go with that, then we are missing the boat. And a lot of online organizations look to, I had to say, make quick money, but they use the banner of access to care, but they don't also include the opportunity for accountability. So if I can use an example, I've run on this year, I'm having more and more women that I deal with in programs like special women's services programs that are for pregnant women or women with young children who are now addicted to different substances. And a lot of these women that we have in treatment now, or even see an outpatient, I ask them, I'm like, how did this happen that you didn't know that you were pregnant? Or maybe they knew they were pregnant, but they said, well, I wanted some help. And so I called into this service where I even showed up to this clinic and they never tested me for pregnancy. They just called somebody on the phone and wrote me a prescription. And so we have a lot of mothers that are now really in crisis. And not only the mother, but of course there's two patients we're treating, a mother and an unborn child, or a young child that's been born with a dependence. And I've asked them, how did this occur? And they would say, no one ever asked me if I was pregnant. No one asked me to do a urine pregnancy test or even asked me if that was an issue. And while we would say, well, the mother or the patient should have told them, well, it's up to us as medical providers and medical teams to ensure that and to be able to educate young women, not only in how we help them with their situation or the medications they need, but also the effects of different drugs, or help them to manage through that if they are pregnant with a child.
And there's been a big rise of the direct-to-consumer concept in a number of areas, shopping, and that's filtered over into prescription medicines. Have you seen that on the rise within Arkansas?
I have seen that on the rise in Arkansas. I see a lot of people, not maybe as much with opiates, but with other medications, benzodiazepines, stimulants, ADHD medicines, a lot of other mental health medicines. And of course, always my concern is that whenever you have the direct to consumer, they're not necessarily checking the prescription drug monitoring program, right? And they may not have the same accountability or oversight of the Arkansas State Medical Board or other insurances here. I understand how people want to access mental health 24/7 online. I looked online and saw Amazon. You had you can pay $35 and get this fixed. And so I understand that there's those different things, but I also have real concerns. And I think ultimately, while there is that push, that what I hear from people again and again is, I'm so glad to get to meet with the doctor in person. Just taking the time to listen to me. Because these other kinds of things, they never took the time to actually listen to what my concerns were and help those patients. And so I think ultimately, patients will come back to that direct physician touch.
And that goes far beyond just even in rural Arkansas too. And that sometimes that healthcare provider is the only person-to-person contact they have.
No, absolutely true. We talk to people all over the state, and I'm a huge rural health advocate. And in talking to people and families about, families loading up from 4 farms, right? And they all get in the truck together. And I was at one conference where a family was telling me, the closest physician to them was 45 minutes, and it was a veterinarian. And so they would go to the veterinarian and they would decide whether it required that they go further in. And so, it really brought to light to me, we talk about access to care and we think about mission trips to other countries and different things like that. But the fact of the matter is we have so much still to solve in Arkansas. And we really need to work together, to not work in silos, but to really work together to solve some of these problems. And for those people who aren't aware of it, call a friend in rural Arkansas. Take a drive, go down like you would Route 66. Take a drive into these communities and see some of it, because there's a lot of stuff that we can still do to help other Arkansans.
Well, before we close, what is the lasting message that you want healthcare providers to know, community partners to know about this epidemic and what's happening in our state? What advice or information that you think is pertinent that they need to hear?
I believe that the medical providers in this state want things to be well for their patients. We've kind of swung back and forth between the opioid marketers, and the crisis is going back and forth. And a lot of fingers have pointed at medical providers. No matter what different people's feelings are on that, the fact of the matter is we know there's some solutions. There are answers. There are solutions. And all of us working together can make those changes. So talking to your patients about their prescriptions and options to be able to either make changes, reduce medicines, or find different options. Always checking prescriber databases or making sure somebody has naloxone. Having honest conversations with people on different resources, and everybody working together collaboratively, we will help solve this problem for Arkansas.
I have no doubt that you will be at the forefront of that change too. Thank you, Dr. Martin, for all that you do. I've learned a lot today, and I'm sure our audience has too. But again, thank you for all that you do and the hard work that you do to make sure that we have a healthy state.
Thank you. I appreciate it.
And that's it for this episode of AFMC TV. Thanks for watching, and have a great day.